Now it's my pleasure to chair this very interesting interactive session based on cases. And of course, I'm pleased here to have to co-chair with Professor Helmi and Professor Ahmed Zaid. And our first speaker, Professor Ali Farag, is well known to all of us, a very competent gastroenterologist and a very competent endoscopist. Is well known for his very interesting talks. So we are looking forward. He's going to present a case controlling post-operative bleeding. So it's time, Professor Ali, the mic is yours.
Dr. Sharif, thank you for your very good introduction to me. Dr. Ahmed Zaid, welcome. Dr. Yusri Bey, Dr. Helmi, thanks for the invitation. I'm going to give a presentation which is very short about a case. I recorded it and it's only 5 minutes. If so, that's the presentation.
أهلا بيكم. النهارده هنراجع أحد الحالات الجميلة اللي بناخد منها مسج. 44-year-old man has Whipple surgery for cancer pancreas 2 years ago. 6 months ago, he was discovered to have a local tumor recurrence as well as hepatic metastasis. A month ago, he started to have melena. Hemoglobin dropped to 5 grams per deciliter, and he required almost 15 units of blood transfusion over the last month. Upper and lower endoscopy were repeatedly normal and failed to show the cause of bleeding. A multi-slice CT angiography showed an operative bed soft tissue mass indicating tumor recurrence as well as metastatic hepatic focal lesions. That's the CT showing the local recurrence of the mass infiltrating the mesenteric vessels as well as the multiple secondaries in the liver. He had a capsule endoscopy to show the cause of bleeding. The capsule showed bleeding in the proximal jejunum, suggestive of a bleeding jejunal varix, so enteroscopy was ordered. قبل ما نقول لقينا في انتروسكوبي لازم نتكلم شويه على الويبل سيرجري. الويبل سيرجري ليها نوعين، نوع اسمه كلاسيك ويبل سيرجري ونوع اسمه بايلورس بريزيرفين. لان احنا العمليه اللي اتعملت بايلورس بريزيرفين هنتكلم اكتر على البايلورس بريزيرفين. ده بيتشال فيها الديودنم كله مع الهيد اوف ذا بانكرياس، بعدين ياخدوا جزء من الجيجينم يوصلوه بالريمننت بتاع البنكرياس، يوصلوه بالكومن بايل داكت ويوصلوه بالبايلورس. يعني احنا المفروض نشوف الحاجات دي لو دخلنا بالانتيروسكوب. اول ما دخلنا الاستومك اهي والبايلوريك رينج، هتدخل تلاقي طريقين. في هنا سمول فيرسز ولكن نوت اكتفلي بليدنج. هنكمل المنظار بتاعنا، ندخل في اول لوب هنا، دخلنا المسافه كويسه اكتر من متر، زي ما حضراتكم شايفين مفيش بليدنج ومفيش سورس سجستيف بليدنج. فكان الحل ان احنا ويزدرو، ندخل في الاذر ليم، لقينا بعض البلاد، كملنا مع البلاد الموجود عشان نشوف جاي منين. لغايه دلوقتي في بلاد بس مش باين جاي منين. هنا البلاد اقل، انها في بلاد كلوتس زي ما احنا شايفين. واحنا كده وصلنا للاخر. عرفنا ازاي؟ لقينا في الستيتشز بتاعه البنكرياس وهو متوصل بجيجينوم. فاحنا هنرجع تاني ونشوف السورس اوف بليدنج فين. لما رجعنا تاني لقينا الاتي: الفتحه بتاعت وصله الكومن بايل داكت بالجيجينوم حواليها فاسكولار مالفورميشنز. هل هي دي اللي بتنزف ولا لا؟ احنا هنشفط ونشوف الامور هتحصل ازاي. لما شفطنا ابتدوا ينزفوا، واضح ان ده السورس اوف بليدنج. طب نعمل ايه؟ اتس ا فاسكولار مالفورميشن. اول اختيار لينا الارجون بلازما كواجيليشن، انما للاسف زي ما حضراتكم شايفين البليدنج بدل ما يقل زاد جدا. دايما عندنا اوبشنز ثانيه، كان احنا نحقن دايليوت ادرينالين او نستخدم كليبس. كليبس افضل في الحقيقه. لو استخدمنا دايليوت ادرينالين بيبقى كتمبري ميجر، يوقف البليدنج شويه لغايه ما تقدر انت تجيب الكليبسات بتاعتك وتستخدمها. ادي اول كليبس بنركبه. وحسينا ان احنا محتاجين كليب تاني to stop the bleeding completely, فوي applied another clip. بعد البروسيدور دي العيان ما نزفش تاني الحمد لله، انما طبعا الكانسر اللي عنده is inoperable. ايه المسج اللي ناخدها؟ when you want to understand go to the basics. لازم نفهم الاناتومي بتاع الجزء اللي هنشتغل عليه، البوست سيرجيكال اناتومي، عشان تعرف انت هتتوقع تلاقي ايه وتشتغل شغل يفيدك ويفيد المريض. Choose your best diagnostic and therapeutic option in the mental work that needs careful planning before actually going to it. Thank you all for this.
Thank you so much
علي.
دكتور علي.
شكرا لحضراتكم.
اتفضل دكتور يسري، اتفضل.
اتفضل يا بيه. Thank you Dr. Ali for this elegant presentation. And if you don't have enteroscopy, what would you do?
في الغالب بعمل بوش انتروسكوبي في البدايه، وبعدين دلوقتي الانتروسكوبي بقى موجود في اغلب الاماكن في مصر، ما بقاش فيه مشكله في الحقيقه.
You have other alternative?
هو المشكله ان حضرتك عايز تدخل وتعمل حاجه بايدك، يعني عايز تعمل انترفنشن.
عمر عندك حل يا عمر؟ unmute the microphone.
في العيان ده يعني لو انا عندي كولونوسكوب بالذات بيدياتريك طويل، جايز اجرب ان اعمل بوش انتروسكوبي، ولكن البوش انتروسكوبي مسافته قليله قوي، بيدي لك 50 to 100 سنتيمتر ات موست.
ايه رايك يا عمر؟
بص، احنا لو في حالات الارتيريال بليدنج ممكن نحقن جيل فوم او حاجات خفيفه، لان احنا بنخاف نعمل باول نيكروزس، ف بتبقى تمبرري ميجر عشان نوقف البليدنج وندي فرصه للاندوسكوبيست انه يخش. في بعض الاحيان الكتير بيبقى الفيلد فيري بلادي ومش بيشوفوا مكان يعني لو النزيف جامد مش بيقدروا يميزوا اماكن البليدنج فين، فاحنا بنقلل الفلو ده وندي تايم ويندو ان نظبط البيشنت ونخليه ان بيتر شيب، والفيري اندوسكوبيست يخش يعمل ديفينيت تريتمنت.
Okay, thank you very much. Speak in English, please.
حاضر.
I have a question to Professor Ali.
Yes.
It's just an interest. This patient did a capsule, did she do a capsule? Did she do it?
Yes.
Yes. So which way did the capsule take? Which loop did the capsule take? And it visualized bleeding. So would you suggest anything, because the capsule will take one of these loops, so it could miss easily the bleeding source?
In my opinion, this was a wrong choice. This is not the right situation to consider the capsule, but it wasn't my choice.
Thank you very much. It's a very interesting question, actually. What way it will go?
It's a curious question.
Yes, usually it will go to the way where there is no bleeding.
No. It will go to the efferent pathway because of the peristalsis. The peristalsis is towards the efferent always.
Yeah.
And were you ready with a hemospray, for example, Ali? Because of course it's a risky case, and maybe the clips will not be satisfactory. Were you ready with the hemospray during treatment of this case?
No, the cause is the cause for not using the hemospray is different from the theoretical one. The hemospray is not that long. The scope is 2 meters. You don't have the
It's not
catheter
horrible
2
bleeding.
meters to be used
Yeah,
too big
it's
for
it
the
seems to be
endoscopy
controllable by
channel
endoscopy.
to be used.
Yeah.
Yes,
Okay.
yes.
Thank you.
Go ahead for the next speaker, Sharif.
Oh, yes, and again, it's my real pleasure to present Professor Omar Al-Asar. He will talk about mixed liver tumor response to local regional therapy, and he is known for his very exceptional cases and very good results even in difficult cases. So he's going to represent one of these difficult cases with an unusual good response probably. So go ahead, Professor Omar Al-Asar.
Thank you very much for the presentation. I would like to thank the organizing committee for the invitation. This is my family, so I always feel home presenting this stuff. And I also want to congratulate Dr. Ahmed Zaid for the HCC group. And I will answer in this presentation many questions that has been questioned in this in our last meeting. So this is, I hope you enjoy the presentation. So we have a relatively young and fit patient. He in early 50s, history of treated HCV. The presentation was LR5 HCC on imaging. He's child A with normal lab, and he was sent to me for this. So he's 52 years old, male patient. Alpha-fetoprotein was normal. CEA and CA 19.9 were non-conclusive. Platelets normal, and all the lab in very good shape. So the patient was child A5. The CT reported a 6 centimeter focal lesion in segment 6-7, oligovascular, showing subtle enhancement in the arterial phase with washout dynamics, and the diagnosed HCC on top of mild cirrhosis. This is the CT arterial phase and delayed phase, and we can hardly identify any enhancement. The region pretty stayed the same through the 4 phases. So the first question, please feel free to interrupt me or ask any questions. This is interactive anyways. So the first question, is the diagnosis correct? Can we proceed confidently with this patient? Again, for me, this is a non-enhancing lesion. This is not washout, and the CT was not the best one ever. So in my opinion, no definite enhancement, no clear washout, no definite cirrhosis, which is a very important factor. We have a history of HCV infection, but no definite cirrhosis. Maybe a typical HCC versus cholangiocarcinoma, but still we cannot exclude metastasis. So again, how should we deal with a non-enhancing lesion on CT? What are the possibilities? In fact,
I have a question here, Omar. Would you depend on the tumor markers like alpha-fetoprotein and the CA19-9 or something like this?
They are strong positive, but very weak negative. I would consider them if alpha-fetoprotein is shooting. I would consider this a typical HCC. I would be inclined, but it's not 100%. So tumor markers assist and direct diagnosis, but they are not definite, and they are not included in the guidelines anyways.
Have you comment, Ahmed, about the tumor markers in such cases, query cases?
As Dr. Omar said, they are good positive, but they are not good negative. وفي الآخر احنا we will depend on imaging mainly on our diagnosis, especially we have patient with HCV and mild cirrhosis.
Imaging or histopathology?
Imaging first. If imaging is not working and there is no enough criteria for diagnosis of the focal hepatic lesion, of course we may pass to biopsy. شوف عمر كده.
I totally agree. So when we have a dark and non-enhancing lesion,
but at least 2 images before biopsy. If we did CT and triphasic CT and it was not conclusive, we have to proceed by dynamic MRI.
I totally agree again, Dr. Ahmed, and we will see what happened in this patient. So first of all, when we have a dark non-enhancing lesion on CT, we have 3 possibilities. Either the CT has a bad technique, or MRI has a bad technique, or the lesion is truly hypervascular, but there is a third possibility that the lesion is truly hypervascular, but on the best CT, we cannot see this. These are exceptional cases. We had a presentation about this, but we always consider that even if the CT and MRI show them as hypovascular, they might actually be hypervascular. So for this patient, we have to check on the CT. we have different parameters that we should check on: the contrast dose, the timing of each phase, should it be repeated if it's bad quality, or we proceed to the next imaging, as you said, Dr. Ahmed. And there is a trick that technicians do when they do a very bad CT. They do a cover-up trick. Let's look at this patient. Here we have a very good arterial phase apparently, but we see no focal lesion in the liver. Can anybody see any focal lesion here in the liver?
No. No.
Okay. This patient, by the way, was Dr. Ahmed's patient, Ismail al-Sheikha, if you remember him. This CT doesn't show anything. Although, if you look at the films, it appears very good. But when we repeated the CT with a good contrast, we can see the lesion here that was totally missed on this one. So what did happen? What did they do? Actually, they increased the contrast. The contrast dose in this CT was very fading or very low. So they increased the contrast as if you are playing on the TV to increase the brightness of the white aorta, to give you the impression it's a good CT, but actually it's fake. So if we look at this image,
Omar, what do you mean by good contrast?
Normally we should have a very good enhancement in the arterial phase through by the contrast we inject. So if you read this, Dr. Yusri, you will see 451 Hounsfield units in the aorta. This will not exceed 170, but the technician, to cover up for this, he changes the window as if you are playing on your TV set and increasing the brightness and decreasing to make it appear white, but it's not actually white.
Why he will change the window?
Because if he prints the film as they are, it will appear that he's very bad. So he have to show the physicians he did a good job. So he changes the window to cover up. But actually, if you have a CD, Dr. Yusri, and you measure the contrast, you will definitely identify it. I'll show you in the same case. So in this very good case, repetition, I mean, we see the contrast dose is 451 Hounsfield units. And by the way, this is a thesis we are working on now in radiology department to know what the threshold level for good diagnosis. So again, this is the contrast modification cover-up trick. I can identify it if I have a CD. So how to do it? Consult a radiologist you trust. If you think the CT is not very good, just take a second opinion. So back to the patient. Should we repeat imaging the CT or do MRI? We went back to the image. Here we can see the contrast in this particular patient, 238, and no enhancing. This is a bit low, not very low, but a bit low. Not the best one. Again, if we compare it to 451 in the other patient, it raises suspicion. Is the CT not good enough? Should we repeat it or do MRI? In this patient, to save the cost and time, we went for MRI as Dr. Ahmed Zaid advised us. This is, by the way, an arbitrary method. If you want to know if the CT is good or bad, just make sure that it's measured above 250 at the level of the renal arteries. Okay, to the next step. This was barely acceptable, so we went on for MRI. The MRI was evaluated by Dr. Muhammad Eid, whom I trust. I think many of us trust him very much. And this is the non-contrast, and this is the arterial phase. And you can hardly appreciate very subtle enhancement in the middle. This is the arterial phase, early venous, late venous, and delayed phase. And you can see that there is contrast fill in. So there is no wash out. This is the opposite. There is enhancement, but there is contrast fill in. This is whiter than this. This indicates fibrosis. And fibrosis goes with cholangio. But with the enhancement early, that goes with HCC. So both together, this is why he suggested a mixed type. So the report, subtle enhancement, progressive fill in, no capsular retraction, diffusion restriction. So it was diagnosed as LRM, which is definitely malignant, but not specific for HCC or cholangio. He suggested mixed HCC and cholangiocarcinoma, but he could not exclude the possibility of metastasis. And then back to your question, we had to go to histopathology. I went to Dr. Yasser Al-Qirm, our oncology professor, made MDT. He requested biopsy, but the patient refused. He was told that it may cause bleeding, may cause seeding, and he totally refused. So the third question is, the diagnosis was now changed for LR5 HCC to LRM, which is malignant but not specific. The patient refusing biopsy, how should we proceed? Actually, we have different therapeutic options, and the patient was young. So many of them were, it's a long discussion. Which one would we choose? Actually, I thought this patient is young and he's got good liver reserve. So I wanted to suggest surgery. Because according to the BCLC, this is a child A patient. He's 52 years old, and I see no contraindication for surgery. I sent him to Dr. Yahya Osman. He discussed the case, and then we did a volumetric.
Can I interrupt you, Professor Ahsar, for a second?
Sure, of course.
It's a very interesting case, really. But I just want to ask you, this patient has a hypovascular lesion, and you are suggesting by an MRI that it has a lot of fibrosis. So this means that you are going towards either a cholangio or a mixed tumor. So how did you apply the Barcelona guidelines in such a case, which is more or less specific to HCC? I would not do this in cases unless I'm quite sure that this is an HCC. Do you have any other opinion?
Yeah, actually, I used the patient actually is better than BCLC. BCLC is made if the patient has to have overt cirrhosis. But actually, this patient was child A5 with no definite cirrhosis. So if you want to treat him as metastatic, surgery is the best case. If you want to treat him as HCC, we will resort to BCLC and his child A on minimal cirrhosis. So in both ways, the decision was surgery. I just put the guidelines as an additional support tools to show why did I go for surgery for this patient. But either ways, if we consider him HCC or metastatic or mixed cholangio, it's the same decision. Okay?
Okay, go ahead.
Okay, so I sent him to the surgeon. We did volumetric, revealing 63% future liver remnant after surgery. So the patient was encouraged, the surgeon was encouraged. Still, the patient started crying, and he came back to me, told me he was afraid of surgery, and his hepatologist, who is Dr. Muhammad Kohla, rejected surgery, and he insisted to go for local regional trial, as he believed the patient might not tolerate surgery. I'm not a clinician. I follow orders. If a clinician tells me anything, I cannot judge why did he say so. I'm not a clinician. So I respect clinicians. Again, now back to local regional therapy after surgery was rejected by both the patient and his doctor. The first question, can we ablate such a big lesion, 6 centimeters? If we do, using RFA or microwave, is TACE good enough? If we do TACE, will the tumor shrink enough to be ablated? First of all, how effective is ablation? This is a study showing that we know, everyone knows that in BCLC we stop at 3 centimeters, and if we go bigger, the results will be much worse. So the odds of failure are staggeringly increasing if we go bigger than 3. And this article published by Livragi, which is one of the best interventional radiologists in the world, he showed us that if we ablate this lesion, our success rate will only be 32.4%, which is a bit extremely low. It's like playing molecular active, tossing a coin. So the patient has a 6 centimeter tumor. In the best hands, only 33% success rate and 67% risking of making things worse. So,
provided that the tumor is HCC.
Actually, Dr. Yusri, this is a very good question. Results in HCC are better in ablation than metastatic or mixed cholangio because of what we call oven effect. Because of the difference between the consistency of the liver and the tumor.
All of us know that locus therapy for cholangiocarcinoma is not good. Results are bad, and even for metastasis,
even
the
worse.
results are not good.
So we go for a smaller tumor. That's the whole point. If we have mixed HCC or cholangio, we should ablate smaller tumors, not bigger. So back to the question: can microwave achieve bigger ablation? The answer is due to inherent tumor factors, anatomy and topography of the liver, heterogeneous field, etc. Microwave doesn't provide a better outcome or longer survival than conventional RFA. It only saves. So the same rules apply. Even if we use ablation by microwave or RFA, the same rules apply. This article is published by Dr. Ahmed Kamal et al. From the hepatology department, and they couldn't prove any superiority of microwave over RFA except for the shorter time, up to 4 centimeters. Another article showing that the superiority of microwave and RFA remains unclear and needs to be confirmed by high quality evidence. So nobody could prove that microwave can go bigger. This is a very important lesson. So what about TACE in this patient? Okay, I will show you another patient and as an example. In big hypervascular tumors, if we can achieve complete response and tumor filling with lepiridol and devascularization, the tumor will shrink, and this will allow for a better ablation. Let's take this example. This is another patient, but just to show the idea, we have a large enhancing tumor, which is 6.5 centimeters. we did TACE, it shrunk to 3.6. This is what we call positive lipidol tagging. I will explain later. We can see the tumor, all the satellites around it, and we could achieve ablation with complete response for 4.5 years for a 6.5 centimeters. But will this tumor do the same? Let's check this.
Professor Asar, this should be in a vascular or in a highly vascular tumor.
Exactly, Afandam. Exactly. That's what I want to say.
It doesn't apply to our case, right?
Yes, exactly. That's the message. This patient, this rule doesn't apply here, what we call positive lipidol tagging, because if we look here, the tumor is not enhancing. Still, I cannot go for ablation. So I thought maybe we can go, maybe shrink it a little bit and see what happens. So this is the oligovascular tumor. As you said, Fandom, a big limitation for TACE, not quite visible during angio, very difficult targeting, and the response will not be that good. If we look to the angio image, we cannot see any tumor blush. You don't see any blush. And even after injection, we can see no definite uptake. So question 5, how can we aim at something we don't see? I'm doing angio, embolization TACE for something that cannot see. So what we do in these patients, we use the CT angio image. We have to have a very good CT in the beginning with a CD, of course. We correlate the anatomy on rotational 3D, and we use the advanced cath lab. I will show you the embo guide, what we call the embo guide. This is a patient with multiple focal lesions. We select the region, even if hypovascular, it doesn't matter. And then the machine will start to show you the track that you should follow to treat the region. This is very high equipment and advanced equipment, but it helps a lot. This is, for instance, a tumor. It shows you all the vessels that can lead to the tumor, and it will allow you to complete the embolization if the patient is fit in one session. If the tumor is too big, we have to split. But if it is doable in one session, we can still do that. We can see here all the vessels highlighted in colors to go to the tumor. So this is what we use for the patient. But at the end, it is fibrotic tumor, non-enhancing, and unlikely to take lipidol. So what happened, as we see here, that the tumor, it took very little lipidol in comparison to the surrounding parenchyma. This is called a negative lipidol tagging. I'll explain again later. So this is the outcome of TACE. After 1 month, I did not expect a good outcome. I told the patient, let's wait and see. So in spite of adequate targeting, we covered the whole tumor, super selective technique. Still, we were expecting rapid washout in short period and a limited benefit. Here we can see the tumor after 1 month, showing very subtle lipidol retention. Still, the tumor was still active, and even the size was a little bit bigger at 6.5. I told the patient, please go for surgery. He refused again. I told him we have only one option to do. We will do what I call commando technique, or something a bit radical, something crazy like Dr. Yusri likes to see. So, sorry?
Salvage TACE, rescue TACE.
Not salvage. I will do it again, but in a different approach. I will explain. So in fact, TACE didn't do any benefits in the first session. The tumor might have increased in size, actually approaching 7, and this is the problem with hypovascular lesions, as we said. The patient and doctor were refusing surgery again. So what our answer to this problem? We will redo TACE only for negative lipidol tagging. I will show you the image. So, and then we will do a CT guided ablation using overlapping technique. Because it's a very large lesion, we cannot ablate it in a single application. And within 48 hours before the Kupffer cells, we'll remove the lipidol from the normal parenchyma surrounding the tumor. Okay, this is the positive lipidol tagging. When we inject the tumor and it uptakes the lipidol, it will stay like this for 6 months, maybe 1 year. We will see the TACE is sometimes curative and or lead to intention to cure. But this is the negative image, the negative lipidol tagging, which means that the tumor did not show any uptake, but the surrounding parenchyma shows uptake. This is not beneficial as an anti-tumor effect, but it shows us the way. So we use this tagging for CT guidance. This is the non-contrast CT if I do it without lipidol tagging, and this is with the lipidol tagging. So I'm just using the lipidol to outline the tumor so that I can ablate really fast. Then we did the ablation 48 hours later, microwave, not radio frequency ablation, first to save time because it is a very large lesion needing many applications. Also, a very important trick about microwave, that we can modify the energy and modify the ablation zone. If we increase the energy and time, we'll have a bigger ablation, and the opposite. So if I want to have a small ablation in the corner of the liver without injuring to vascular structures or nearby organs, I can do it. or I can increase to encompass a larger area of the tumor. Also, the microwave will overcome the heat sink effect because this tumor, as we will see now, was juxtaportal, close to the portal, and also the patient could afford the cost, so why not save him the trouble? The aim to cover the tumor in this configuration, it's extremely difficult. So to do it, we have to have at least 5 overlapping ablations for this size. We use ultrasound only for initial targeting, but the CT is used for repositioning because the gas after the first application, the first ablation, will totally mask the field. We will not see the needle anymore after the first time. So we use the MPR, multiplanar reformatting of the venous face from the CT and the non-contrast CT and the lipidol tagging to put the needle in proper place. Let me show you the difficulty. I will call this radiological surgery because it's actually surgery. So these images are extracted from the portal venous phase of the therapeutic study. We need a very optimal CT quality, CD, and we start to measure the distance between different organs, the risky areas and stuff like that. Look at these images. Let's get a little bit crazy. So this is the tumor, and this is the hilum, and this is the bifurcation of the portal vein. We can see here also an accessory right hepatic vein going behind the tumor. Look at this one. This is the portal vein. This is the tumor, and this is the bowel. We all know that exophatic tumors should not be done. I will show you how we did it. It's a bit crazy. This is the right hepatic vein coming from up and going to the tumor. We have to be aware of every structure nearby to prevent any complications. If we don't do this, it will be catastrophic. Again, this is the portal vein touching the upper part of the tumor. So that's why we prefer microwave in this patient. So using this multiplanar reformat, we make a plan. The yellow arrow represents where I want to put the needle. We calculate the ablation zone, the safety margins. It's a very complicated, it takes a long time, but I enjoy it so much. So using this multiplanar reformat, we calculate the angle, the distance, the safety, everything. So question 8, can we ablate exophatic tumors? Can we ablate near the bowel? Let's find out. Dr. Yosri always wants to see a little bit of challenging cases, so that's why I chose this one. Let's burn the thing. Let's play with fire. It's actually fire ablation. So we do this procedure under CT guidance and with ultrasound guidance at the same time, based on the, as I said, the multiplanar reformatting images. And the idea of lipidol tagging, even if negative or positive, it's permanent visibility. I can reposition the needle without being overcome by the gases that will be produced after 4 or 5 ablations. The outcome, we did surgery for the patient under local anesthesia, 90 minutes of work, no blood transfusion, no ICU admission, and the patient went home the next morning. This is the 3 months post-ablation MRI. We can see the non-contrast phase, the ablation zone surrounding it. This is the gallbladder. Again, this is the arterial phase, no enhancement in anything. You can see a very nice ablation zone surrounding the tumor. The kidney is intact. Again, the gallbladder is intact. We had complete response. 12 months post-ablation, which was only a month ago. Again, we can see that this is the non-contrast phase. Lipidol is seen inside the lesion because we ablated this lipidol. So the phagocyte, the cover says we cannot eat it anymore, cannot engulf it anymore. So it stays forever. We can see here the ablation scar and look at the coronal view. This is the venous phase to show you the structures. And this is the lesion, the tumor inside, the bowel is intact. The IVC, this is the bowel as well. And everything was pretty fine. So apart from mild fever, the patient was totally, even he didn't suffer from any pain. I thought he would be devastated by pain, but he didn't suffer any pain. So question 9, if I'm starting my career in ablation.
Omar, I see that you just ablated the liver around the tumor. Yeah. Am I correct?
No, Dr. Yosri, the tumor.
The tumor actually, is still inside that area. I see an area of ablation around the tumor.
Yes, this is coagulative necrosis. This is coagulative necrosis, Dr. Yosri. If you check this patient with non-contrast, all of this and all of this, it is the same enhancement exactly. This is lipidol because we injected the patient and we ablated 48 hours. I call this.
Yes, I would like to know your principle. Your principle in doing this, you ablating around the tumor or the tumor itself?
Everything. The tumor itself and the tumor and the safety margin around it. The needle is put, we put the needle like this, if you see the arrow, and then the ablation will cover the whole area. Then we position and take a smaller area from here, and then safety margin from here. But everything is ablated. This is all the coagulative necrosis everywhere.
هو حدد السيفتي مارجن بتاعه يا دكتور يسري على الليبيدول تاج اللي هو عمله بالسي تي
في المره الاولانيه.
المره الثانيه.
اوكي.
But everything is ablated.
I don't see. Let us follow.
Okay. In the arterial phase, there is no enhancement by this is identical to this. So this is lipidol. There is no additional enhancement in the arterial phase. Okay. So this is the coronal view again. You can see that this is ablation scar, the safety margin, and the tumor has been ablated even if exophatic. So if someone is beginning his career, please, is it safe to ablate exophatic tumors? Absolutely not. It is not safe. There is another way that we can do. I showed it in a previous presentation, what we called hydrodissection or artificial ascites. But in this patient, using the multiplanary formatting and very complicated calculations, we could do it safely without using artificial ascites. So please be advised, please take care. The last question that Dr. Yosri already asked, is this limited to HCC? Actually, no. In fact, this is totally the opposite. This negative tagging technique we use it mainly in the metastatic lesions, cholangiocarcinoma, or other hypovascular lesions. It allows us to go bigger on a lesion we don't see. So most solitary large SCCs are hypovascular and can be treated by positive tagging, like the patient I show you, reaching size reduction and then followed by ablation after 3 months, 6 months. But in this case, we do the negative lipidol technique. We do the ablation within 48 hours. We did 10 metastatic patients with negative tagging. The pilot study I will show you in the next conference, inshallah, online, the face-to-face. I will show you the new study about the liver metastasis, which is very promising. Thank you very much.